You're listening to Girls with Grafts, a burn community podcast created by Phoenix Society for Burn Survivors, a leading nonprofit dedicated to supporting the burn community. In this podcast, we'll talk with burn survivors, share resources to help with supporting and improving burn recovery, and discuss how to prevent burn injuries. Here are your hosts, burn survivors and Phoenix Society's marketing team, Amber Wilcox and Rachel Kudlak.
Hello, everyone, and welcome back to Girls with Grafts. I am Rachel Kudlak. I'm one of the hosts of the podcast, and today I'm joined by my lovely co-host, Amber Wilcox.
Hi, everyone. Thanks so much for joining us. Today, we have a special treat. Really excited for today's podcast. But as always, we're super thankful for those that make this podcast possible. So without further ado on that one, Rachel, if you could introduce today's podcast sponsor.
Yes, so today's podcast is powered by Grafts, a personal injury firm dedicated to supporting burn survivors in New York and New Jersey. They understand the physical, emotional, and financial challenges that come with burn injuries and fight tirelessly to secure justice and compensation for their clients. You can receive a free consultation today by visiting grafts.com, and we'll make sure we have their contact information in our show notes as well.
Awesome. Well, today's podcast sponsor, we're thankful for today's podcast sponsor. We're tongue-tied today. But I had the opportunity to meet Dr. Victoria Miles a couple of months ago now, I think. And we were able to connect about some really cool stuff. And so I'm excited to have her on today's podcast. Rachel, will you read her bio so that everyone can know a little bit more about her before we bring her on?
Of course. So as Amber mentioned, today we have on Dr. Victoria Miles, who is an assistant professor of burn surgery at the University Medical Center, New Orleans, affiliated with LSU Health Sciences Center. Originally from South Mississippi, she worked as an EMT paramedic while completing her education and now teaches in Holmes Community College's critical care paramedic program. Dr. Miles earned her medical degree at the University of Mississippi, completed residency at UT Chattanooga, and specialized in surgical critical care and burn surgery at UT Southwestern, where she received the Top Knife Award. Her research focuses on burn education, resuscitation, and limb salvage. She leads the American Burn Association's mentorship program, serves on multiple committees, and has authored over 35 publications. And in her free time, she enjoys traveling with her husband, Dr. Daniel Miles, an orthopedic trauma surgeon. So thank you so much, Dr. Miles, for joining us today.
Yeah, thanks for having me. Excited to be here.
Yeah, so I know Rachel just read your bio, but we always like to learn a little bit more about how you got involved in burn care in your own words. And so I know that you're not a burn survivor, but you do deal with burn survivors like Rachel and I quite a bit. So we'd love to learn a little bit about that to start.
Yeah, absolutely. So I became a paramedic, honestly, to pay my way through college and med school. So I was supporting myself. So I would work full-time on the weekends, 36 and 48-hour shifts alternating all through my training. And I think from a paramedic perspective, most people think, oh, you're going to become an emergency medicine doctor. And I ran into some trauma surgeons. I said, well, man, that's really cool to do trauma surgery. And you get to be the kind of definitive, I guess, healer of these trauma patients. And so I went into surgical training thinking, oh, I'm definitely going to be a trauma surgeon. But then I rotated on burn. And so, in many places, burn is a division of trauma. So I could still be a part of resuscitation and critical care. But I really loved being able to see my operative work. You do an appendectomy where you remove someone's appendix and you never can see on the inside again, right? So I loved being able to see what you did. I had a very formative patient for me where my attending had let me sew on a part of a hand graft. And I remember my patient went back to gardening and how meaningful that was. She was elderly and so sweet. And that really did it for me. And then I think a couple of other things that are unique to burn. So we're one of the only surgical specialties where all members of the team go to the national meeting, right? So if surgical oncologist, it's just a room full of surgical oncologists, and not just, they're incredibly smart and gifted. But ABA for me, I mean, you're there with your entire team, from pharmacy to therapist to everyone. So that really drew me to burn, and just realizing that without the knowledge and care of all of these different members of the team, your patient would have a poor outcome. So no matter what I do in the operating room, if I don't have all of those team members, then things won't go well. I really liked that. I really liked working in a team. I think you feel supported when all the members of the team are trying hard, whether things are going well or not going well. So then I really transitioned from thinking I was going to be a trauma surgeon to knowing that I was going to be a burn surgeon. And then I think from a research perspective, I've always enjoyed resuscitation. I'm a very algorithmal person, and that's a huge part of burn. I love math. I love numbers. I love data. And resuscitation is really that. In a large way. So critical care and resuscitation fell well into that. So yeah, here we are.
Well, I think it's really cool that I didn't realize you get started as a paramedic, and that's probably a really good way to figure out if you really want to be a doctor, because I'm sure you see everything. I know I couldn't do it, but I'm sure like there were things that you learned there that and I think it's a great idea, because I'm sure there are folks out there that go to school to be a doctor, but then have no idea like what they're getting themselves into. Do you feel like you've always grown up being like, yeah, I love blood and guts and all those things? Or did you, were you shell shocked, I guess, when you went into it? Like, oh my gosh, there's a lot I didn't realize.
So I will tell you, there are not a lot of female surgeons from the Southeast, and I'm originally from Mississippi. And I have to give credit to my mom in this moment. So my mom was a middle school English teacher, not a surgeon. And I remember I came home from school one day, and we had to write an essay, 3rd grade. We have it framed, about what I wanted to be when I grew up.
Amazing.
And I told her, oh, I'm going to be a nurse. And she said, no, ma'am. You're going to be the head surgeon. It's just like working on a car. You can do it if anybody can. You're the smartest girl in your class. And so then I wrote this essay about how I was going to be a surgeon. It's just like working on a car, because my mom told me to. And then I think it just became a self-fulfilling prophecy after that. And I didn't really know what I was getting myself into. But to your point, I tell people often, I know, and this is no discredit to my medical school, but I learned more on the ambulance than I ever did in medical school, for sure. Mm-hmm. During such formative years, right? Because I became a paramedic when I was so young, like 18 to 19 range, if I remember correctly, but right around in there, 18 to 20 years old. Actually, I became a paramedic before I would fall under the insurance to drive the ambulance. You had to be like a certain age. So I always had to be in the back of the truck. I couldn't drive, but I could take care of patients, which is ironic.
Yeah.
But those are formative learning years. Your brain is more plastic during that time. And so I was just soaking in all of that information. But I think I definitely learned more. I definitely advocate for anyone who's interested in going into medicine to consider that route, because it was so helpful for me to come from that direction. I'll tell you something surprising for people too. It really taught me why a lot of people struggle in life. So when you're going into people's homes and seeing where they live, especially in lower income areas, you really start to understand how it's not easy for everyone to accomplish everything. And I think that was really helpful for me as a doctor to learn, not everyone can go to Walmart and buy whatever they want to eat, right? And some people struggle with just that. And I think that was really, really helpful to me to see living conditions in rural Mississippi, and where people come from, and learning to respect that and honor that and appreciate that was really, really helpful as well.
That's really, really beautiful that you can acknowledge that, especially in the medical field, because it can be hard to just be like, well, why can't you go get burn supplies or things like that? So I really appreciate the fact that you said that.
Thanks.
Well, I do want to dive a little bit more into burn care and your specialties. And I know kind of talking a little prior before we're recording today, wanted to talk about nutrition and some, burn hypermetabolism, for example. So maybe we can start there. I know, that's a critical issue for burn survivors. So can you just maybe tell us a little bit more what that is exactly and why it's a unique challenge for burn care?
Yeah. So I will tell you, this is one of the major reasons. Another reason I didn't mention that I went into burn, because I think it is fascinating. And I think it's something that is difficult for our patients to understand. So in preparation for us meeting, I wanted to provide you with some examples. But when your body experiences a thermal burn, so a heat burn, so we're not talking about a friction burn, but a thermal burn from a scald or a flame, you have this huge inflammatory response that occurs from that. And your body releases a large quantity of catecholamines and hormones and cytokines, and this huge storm gets released in your body. And what's funny about that is that if you have a major trauma, let's say you have a broken pelvis and a femur and a traumatic brain injury, your body will stay in a hypermetabolic state for 3 to 5 months. Burn patients, major burns, up to 3 to 5 years.
Wow.
It's a huge difference, right?
Mm-hmm.
So obviously my ICU patients are going to be treated very differently than trauma ICU patients, right? And you definitely can appreciate that it's a long game with burn. So the catecholamine surge that you get from burn is 50 times normal. The only other time humans experience that is in labor. So you think about this is a huge inflammatory surge that exists and persists for quite a long time. And we have to do something to combat that hyperinflammatory response, or the body just kind of whittles away because it's expending all this energy on top of even thinking about trying to heal these wounds and everything. So it's something that burn hypermetabolism and subsequently nutrition is something I've developed this deep interest in, investigating, and then all of us combating, because none of our grafts will ever heal if our patients are not in the right state. So and I think it's something that patients aren't as aware of as being so important. You're told to drink protein shakes, but I think a lot of my patients ask why, right? And you add that hyperinflammatory state to the fact that your burn wounds, the yellow discharge you get from your burn wounds is protein. I mean, I try to explain on your dressings, that's protein. So on top of constantly leaking protein. So it becomes a central focus, after resuscitation of burn care. And I think it's something that's poorly understood. I will tell you, my surgical residents come on, have no understanding of this, right? It takes me a long time to teach them these concepts. So I thought it'd be something interesting for us to talk about.
I think that's really important, because you do just talk about protein shakes, right? But we don't hear about like the nutrition aspect. When you say the 3 to 5 years, does that like depend on the severity of a burn, or is that so what's the severity level for something like that?
So hard to predict. Everyone's different. But we say that burns over 20% are going to have a prolonged hypermetabolic response, more prolonged for your even bigger burns or massive burns. But everyone is different. So in our clinic, we do resting energy expenditures. So you breathe in and it calculates how much your metabolism is running, let's say. We do that once a month for our big burns after discharge to try to see when we're reaching back to a normal state. When are we getting back to where we were pre-burn? Because for everyone, that's different.
And so based on that, they're breathing in, how are you treating them with that metabolism, understanding?
So I think that's kind of the next thing I wanted us to talk about. So I think we do so many things in burn just because of this issue. And so I think that's why it's so important for patients to understand this, because it's so much of the reason that we do what we do. So obviously your dietitian coming to see you and tracking anything you eat is so important. And then when you go in the clinic setting, tracking, everything that you eat, you think about our patients deplete their vitamin stores faster. So their bodies are in overdrive. So we measure levels of copper, zinc, vitamin D, vitamin A, vitamin C, Those are all critical to wound healing. And so you have to measure those levels and replete those things. We try to start tube feeds on patients with burns over 20% within the first few hours of arrival after we know they don't have any major trauma. So within the first few hours. We did use a drug for a long time that probably a lot of people listening to this podcast may have taken. So I wanted to make sure I mentioned it. It's called oxandrolone. And that was kind of like a testosterone analog to push you to an anabolic state rather than a catabolic state. It was abruptly taken off the market in 2023 with no pre-warning given to the burn surgeons, and most major burn patients received that drug. So we're now investigating, as we're the primary center, and I'm the lead investigator on a multi-center trial now. We have about 10, 11 centers that are enrolling patients that are trying to use human growth hormone, testosterone, or just trying to take care of burn patients without having oxandrolone. So just standard of care, we're calling it, not receiving any drugs, and to see how those patients do and how well they heal their wounds in light of the fact that we no longer have oxandrolone and it was pulled from the market. You remember—
Do you know why it was pulled from the market?
So no one does, actually. I think there's a couple of theories, and I won't share those. But I'll just say that there wasn't any major reason that was given, and I'll say that there was a small population of patients using that drug. So I'm not sure, and I don't. It's the FDA announcement says the risks outweigh the benefits, but it was a very safe drug in our patients. We didn't see any major side effects, so I question that, and I question that rationale. But we're trying to find solutions and see what the best thing would be going forward. A lot of burn patients, you probably sit home on propranolol. So propranolol, when you have this hypermetabolic state, your heart just runs so fast. So burn patients without being treated can run heart rates at baseline of like 120 to 140, where normal heart rates are 60 to 100 or 60 to 90. So we'll give patients propranolol to help keep their heart rate lower, to decrease that hypermetabolic response. We do a lot of therapy. So early therapy will help combat the muscle breakdown. So early therapy, wound therapy. We have a skeletal muscle mass scale here where we measure skeletal muscle mass and monitor that and make sure we're not losing just more and more muscle. We're investigating when that plateaus. So when in the burn course, I guess, when does that plateau depending on the size of your burn? And then, we also focus, especially on my side of things, is getting wounds closed decreases the protein loss. So grafting and getting wounds closed as soon as we can. We also know over the last, 20, 30 years of research that the burn injured skin is driving this response. So that's why most centers have moved to an early excision model, meaning you want to get the burn excised, within 3 to 7 days at the most, if you can, if the patient's stable enough to be able to undergo the operation, because that can help slow down that hypermetabolic response and that release of the inflammatory mediators. So I think also another component that maybe is undervalued is managing psychological stress. So managing stress also decreases that response. So I think, it's funny. I just told you 20 things that we do in burn care, all because of this one central concept. So once you understand that kind of central concept, it's like, all these other things make sense as to why we do what we do.
I want to take a minute and go back to some of that nutrition, because I think that's really important. We do hear or I've, been told a bunch of times, drink your protein shakes and whatnot. But is there a better approach to just drinking your protein shakes that you foresee? Especially, I think the biggest challenge I think we see, and kind of going back to a little bit about the you never know someone's situation, right? Not everybody has access to healthy foods, right? Or whatnot. So let's, for a moment, I guess, focus on that, right? What is the one takeaway of you have this large burn, you're leaving the hospital, what should I focus on?
So I tell my patients that when you get a plate of food in front of you, a lot of times burn patients don't have a big appetite. They don't feel like eating. They're taking medications that also, adjust their appetite as well. So when you get a big plate of food, I want you to eat the protein first. So if you can at least get the protein in, then I will be happy, right? So don't prioritize the potatoes or the pasta or the rice, even though when we're sick, a lot of times that's what we want to eat. So really focusing on prioritizing whatever protein you have available to you first. And then also just taking a multivitamin every day. So I do that. So I practice what I preach, but I do that. But just taking a multivitamin every day can make a big difference as well. But prioritizing protein, and I always tell people any brand, whatever, from Walmart, but taking a multivitamin and prioritizing protein. I will say you have to be very careful because we use the Core Power shakes here. The Premier protein shakes are very good. But you have to be careful with supplements like Ensure. Those are actually really high in sugar. So picking out any kind of protein drinks, you want to, like the Fairlife milk also has a lot of protein in it, but you want to look for something that has a higher protein content than carbohydrate content. And that's really what's going to help you heal your wounds more than anything.
And yeah, do you have any tips specifically for parents who have children burn survivors who, don't always want to eat maybe what they should be eating and you just want them to eat, so you'll give them anything? So do you have any tips for them?
Peanut butter. So peanut butter is very high in protein. So most kids will eat peanut butter unless they have an allergy, obviously, but peanut butter, that's one. The Fairlife chocolate milk, like I said, very high in protein. So Fairlife chocolate milk, those are two of our tricks that we use. And then a lot of times, and this is a good trick for kids, our dietitian for some of our more picky or discerning eaters, and we mostly have adults, but she will actually take a scoop of ice cream, a scoop of peanut butter, and mix it with a protein shake. We call them mass gainer shakes, but she mixes them herself in our unit. So there's some patients that just hate the taste of protein shakes or grow to hate the taste of protein shakes. So add a little banana, a little peanut butter, and mix it up like a milkshake, and that's a lot more fun. So
definitely.
No, I know. Oh, go ahead.
Well, I was just going to ask, like, when, and I know obviously working with your burn care team, they'll help you kind of identify this, but I know some survivors then will struggle when they get to a point where then they're just consuming so many calories because they're used to it. And then decreasing that calorie count can be really tough. So when is that time appropriate? And do you have any tips for when you're supposed to be decreasing?
That is, I knew you were going to ask that. And that's as you should, because I get that question a lot, which is one of the reasons we have started here to continue to do the serial measurements outpatient, because you definitely don't want to swing the other direction, right? So I think in general, and these are general rules, so no one anywhere, no surgeon can say, please don't tell my patients that. These are general rules. Please follow your surgeon's guidelines. But in general, once your wounds are closed, meaning you don't have open areas anymore, you can start to wean off protein. But then I think at home, the easiest thing to do is to monitor your weight. So if you're continually losing weight after you start weaning off some of those things, then you need to pick back up on your higher protein, higher caloric foods. So if you don't have access to the serial metabolic measurements, that's what I would recommend. So I wouldn't stop protein supplementation while my wounds were still open. I would take a multivitamin for the rest of my life to ensure that my wounds stay healed and that I'm healthy. But I think you can begin to wean that once your wounds are closed while carefully monitoring your weight. But it's tough. It's really hard. And I know it frustrates a lot of my patients very reasonably. It frustrates them because it's like, you were telling me to eat all this food before this. I ate 1,500 calories a day and I watched my figure and whatever. And I totally respect that. It's a tough balance though. But I think serial weight measurements are important to just make sure that you're not falling off that kind of trajectory.
I also want to talk about drinking, because I know in addition to eating, like for the first, I think it was like week, they wouldn't let me drink any water, and it was like all I wanted to drink. Is that still something that you focus on, is like no water in the first set of time? And what do you do for that?
So we'll tell you something interesting, I think, has kind of transitioned. So obviously you can't drink before you're going to have anesthesia. So sometimes that's the limiting factor early on. But, with the IV, are you all aware of the IV fluid shortage that we had this year in America?
No,
So
I did not.
all the flooding in North Carolina, all the floods in that part of the country.
Yep.
It took out one of our biggest producers of IV fluids. So the hospitals were being reasonably very stringent on who actually needed fluids, right? So, for instance, if you're going to have your gallbladder out at 7 a.m., does everyone really need fluids from midnight to 7 a.m.? Most people don't drink from midnight to 7 a.m. So it would be holding IV fluids on those patients if their renal function was fine, if their kidney function was okay. So as burn surgeons, our large burns will receive liters and liters and liters and liters of fluid. So we really had to come together as a burn community and say, what do we do? Because we don't know when these fluids will be back. As a side note, almost all of this is resolved now. But so we've started a lot of oral rehydration protocols. The World Health Organization has an oral rehydration solution for people who don't have access to IV fluids. So there's a lot of oral rehydration protocols being used now, and oral resuscitation protocol is what we call it. So we've done that on some of our burns that, are 20 to 30%ers, maybe even up to 40%ers if someone's real compliant and motivated. And we've had some success with that this year in oral rehydration. But I do think, a lot of times when you're acutely ill or you're on agents to help increase your blood pressure or you're going to be going for surgery, there's a lot of times where you're told you can't drink anything, right? Sodium levels, salt levels are affected a lot by the resuscitation too. So sometimes we'll limit people the amount of just plain old water, as I would call it in Mississippi, the plain old water you can drink. And then sometimes we'll say, we just need to have you drinking Gatorade. Right. We need you to have you drinking some kind of salt solution in this time because your salt levels are low.
Right. Sure.
Yeah.
And I know at the beginning you talked, one thing you love about burn care is that how it takes a village. You're working with not just surgeons, but the nurses, dietitians, physical therapists, the whole team. So can you kind of talk about how you do work, especially with like the, dietitians specifically, to create the proper nutrition plan for a patient, or kind of how that dynamic works?
Absolutely. So what will happen, this is at least at our center, is our dietitian will collect food preferences for the patient. So that's very important and something we should all acknowledge. Also, favorite flavor of protein shakes. We have a whole protein shake fridge in our hall in the burn unit that just has Core Powers and vanilla, strawberry, and chocolate. So she helps ascertain preferences. And then we also always need to identify if someone was malnourished before this happened, right? So then we know their trajectory is going to be more difficult. Their wound healing is going to be more difficult if they had, say, lost 20 pounds unintentionally in the 3 months prior to having a burn. And then she does the serial measurements of the energy expenditure and kind of what the metabolism is doing. So she does those serial measurements in combination with our skeletal muscle mass and tells me as the surgeon, this is what I think needs to be happening. This is what I think. This is how much the patient's taken. And really the dietitian plays a key role of tracking meal intake, breakfast, lunch, and dinner, letting us know if we need to add some type of appetite stimulant. So it's a really close relationship, and she rounds with our team every single day. So that tells you how important that is to us, but she rounds with us every single day. And then also sees the patients in the outpatient setting for the larger burns.
Now, correct me if I'm wrong, but not every burn center has a dietitian, or am I making that up?
I can't. So it's a requirement for American Burn Association verification. So it is definitely a requirement for verification. So I can't speak to unverified centers and their protocols, but at least for all of the ABA verified centers, it is assuredly a requirement.
Okay, that's good to know. I remember last year at ABA, I had met a new dietitian. It was like her first year at the conference, and she was new to burn care. And I couldn't remember if she was saying that because she was new or because like it was not every burn center had one. So I was just curious to know.
And it's tough. It's tough to find burn specific dietitians. So in one of my roles is I direct the ABA mentorship program. So anyone from a member of a burn team can say, you know, I have these goals, I want to accomplish them. Can you pair me with a mentor within the ABA? And it's hard to find burn specific dietitians. They have a big job. It's a big undertaking for sure. There's a lot of patient education that goes into it over a prolonged period. So we're really trying to encourage more dietitians to be involved in the ABA. And to have their input because it's critical. So I did a big call. The ABA has a division called the nutrition interest group. And so I did a big call to the nutrition interest group looking for experienced mentors the other day, about a month ago, actually, and got some replies and got a young dietitian set up with one of the more experienced burn dietitians because those dietitians do something that doesn't happen in the rest of the hospital. So there's no other condition in medicine that has a higher protein requirement than our large burn patients do. So it's a different world. So anyway, they're critical to what we do every day.
Definitely.
That's awesome. I do want to focus a little bit about some of the other research that you're doing, if you're doing any additional research, and if you could tell me like, what is some of the new, I know we talked a little bit when we met in person about some of the other advancements and things in burn care that are going on. I would love to just spend a few moments like learning a little bit about what else you're doing above the hypermetabolism.
Yeah. So I love to teach. One of, I guess, my funded research is with military education. So we have a grant from the Department of Defense, and we're working on a tabletop-based burn education platform that'll be in real time and for paramedics and flight paramedics prior to deployment overseas for all of the burns that they will encounter overseas. I just got back from Fort Sam Houston with the critical care flight paramedic team there and meeting with them and learning about what they do with our whole research team, not just me. And we've paired with the ISR to do that. And so we're developing that, and that takes a good bit of my time. We want to make sure that content is verified and valid, and constructed with validity as well. So that's a major part of my time, is developing that with the hope that after we develop it and are able to input these scenarios, that then that could be transferred to the civilian setting and be used for anyone who doesn't have formal burn training, whether that be an emergency medicine physician or a paramedic or a flight paramedic or, nurses or whoever. So that's the eventual hope. And I will tell you, it's beautiful. So we pair with applied research associates who are also used for like AI national security. And they have developed the most beautiful, like high fidelity program. And we're really excited about that. So yeah, that's a big part of my research. And then outside of that, I have done some research and continue to do some research with some skin substitutes. So primarily biodegradable temporizing matrix and their unlaminated version, MTX. So skin substitute research, and then also some RECELL research, I think would be my biggest projects. We do, my partner, Jeff Carter, who's this coming on ABA president, has a huge interest in health economics. So sometimes I help him with some of his work as well. But I think personally, those would be my biggest vested interests.
So we were going to spend some time talking about your partner. I didn't realize that he's the upcoming ABA president. That's really awesome. And remind me, you also were involved in the ABA as well in terms of leadership, correct?
Yeah, so I'm on the ABA Membership Advisory Committee, and then direct the mentorship program, which is funny because retrospectively, as a first year resident, I was one of the first classes of mentees. So that's kind of full circle. Callie Thompson, who's a burn surgeon in Utah, was my mentor. And then it's funny to now kind of direct that program and shape that program some. And then I'm on the ABA Reconstruction Committee. So I think my primary role in that committee is we worked really hard to gather where patients can seek laser therapy. So there's a list now published on both the ABA website and on the Phoenix Society website of what centers offer laser treatment for scars. And so that's posted now, and took some time to try to figure that out. That's posted, and every ABA, I try to update it in different sessions so that patients will have that knowledge and be able to see where those laser treatments can be found.
Yeah, that's awesome, because I think that's a question I hear often is, how do I get laser? And because not every burn center offers it or has the opportunity to offer it, which is really wonderful.
Correct. Yeah. So we realized and recognized that. I think it's definitely, a game changer in burn care for sure. Makes a huge difference for patients. And so we wanted to make sure that people had access to, where can I seek this? What's most convenient for me? And so that list is published on the Phoenix Society website now.
Yeah. Awesome. We'll make sure we have that linked below.
Oh,
one question I did have too, and I should know this because I got lasers done before, but can you talk about, are there different nutritional needs after laser surgery that are different? Obviously, a skin graft is much larger of a surgery and there's so much more healing with that. But is there anything specific we should be aware of for lasers specifically?
Not really. No. Okay. Not really. I would say just maybe increase your protein intake a little bit afterwards, because you will have some leakage from your wounds, but nothing near like your initial burn in any way. A vitamin. But other than that, no. No major diet.
I'm going to make sure I take my vitamins after this, because I feel like that's not something I was even aware of, but I think is very important.
Yeah, there's a large number of our patients that even on admission have significant vitamin deficiencies. And I think some of that just comes from the American diet. I think some of that comes from food preferences. I think some of that comes from food availability, right? And so a lot of our patients will show up with low vitamin C levels, low copper levels, low vitamin D levels, low zinc levels. And so I think it's just really important for all of us, especially we're all really busy, and we all have busy lives and a lot of things going on. Just taking that multivitamin just ensures that you're getting most everything that you need. So I'm a big advocate of that. I know some surgeons may disagree with me, but I definitely know it's not hurting anyone to take a multivitamin every day. So if I tell all of my patients that always.
Definitely. Well, I know you talked about some of your research, and some of that sounds so exciting. Some of it is a little over my head, to be honest. I'm like, okay. But that's why we have folks like you who are the experts in these fields. But is there any particular, like, one thing or maybe a new technology that you're really excited about that could really change burn care or healing for survivors?
So I think there's a couple big things kind of on the horizon, and a couple of things that I would say recently happened. And when we talk recently in research, we mean in the last 10 to 20 years, right? So, we do a lot of what we call the spray-on skin. So at least in New Orleans, where a lot of our patients have darker pigmented skin, as surgeons, we rate that on the Fitzpatrick scale. So a 10 would be someone who has very dark skin, whereas 1 would be someone who's very light skin. There's also different Fitzpatrick scales with different numbers, but whatever. So you get on the low end or the high end. But all that to say, for our highly pigmented patients, that's been a game changer for those patients, because the pigmentation of their skin really matters a lot to them, and it's a sense of identity for them. And I totally understand that. So it also helped, when you think about skin grafts, you have that kind of meshed appearance once they heal, and the spray-on skin has really helped heal the interstices where the little gaps are a lot. And I really think it's improved the cosmetic outcome in burns. And I did one of the first spray-on skin cases as an intern a long time ago, intern resident, first year residency, with Steve Kahn. And it's just amazing to see how far that's come. I think we pulled data recently, and in the last 5 years, over 6,000 patients have received spray-on skin. And that's incredible. And I think people are really seeing the value in that. So that's one. I think also anyone who's had a major burn has probably been in a skin substitute of some sort. So whether that be cadaver skin, also known as allograft, some people in the past received xenograft, that was pig skin or porcine skin. We now have a fully synthetic dermal substitute called biodegradable temporizing matrix on the market. The price is really reasonable, and we're having a lot of good luck with that. I know when I was at Parkland and training, and then now in New Orleans, that's what we use in 90% of our cases with really good outcomes. So I think that's big. I think it's big to have a fully synthetic, no biologic components. And that's big for burn patients and really helps with filling deficits, with temporizing patients until they're ready for skin grafting. So that's kind of been a game changer. And then lastly, I'll end, and I will preface by saying this is not my area of expertise, but it is one of my partner's areas of expertise. They're developing a camera that can take a picture of burns and burn wounds and determine if they need to be skin grafted or not. I think a lot of the struggle with burns is knowing, does that patient need to be transferred to a burn center? Are they going to need surgery? Is this going to heal without surgery? So they're developing this camera, and that could really revolutionize burn care, burn triage, making sure the sickest of the sick patients have room to be in burn centers. It could completely revolutionize that. And so I think that's kind of the next thing on the horizon. And there's a lot of other implications. We could be using it intra-op when we're not sure with our own eyes if something's going to heal or not. And in the operating room, take pictures and it tell us exactly what we need to graft and what might heal on its own. Because right now that's all visual. And so having this definitive tool to direct us as to what we need to do could completely revolutionize burn care.
That's really awesome. I didn't even know that was something that was being done. So I can't tell you how many times I've heard like, oh, I'm at a hospital that is in a ABA center and they don't know whether or not to, like, what do you know what I mean? What should I do? And so that's a really, I think, awesome thing that is being developed.
I think so too. And, I think you also have to consider is, let's say, for instance, what happened on Bourbon Street in New Orleans on January 1st. If there were multiple IEDs that may have exploded, fortunately, they didn't detonate and they were able to recover those. But, if we would have had 30, 40, 50 burn patients here, we couldn't take care of that many patients at one time, at least in our center. And so it's inevitable that some of those patients will have to go to non-burn centers. So especially in a mass casualty event, that could be critical to have the ability to know, which patients need to be grafted and who don't. And then with the extreme shortage we have of burn surgeons in the country, that technology also could really help a lot of people. So that's something that I'm really excited about.
That's awesome. I know we're almost towards the end of our podcast, but I want to spend a few moments talking about you and your husband, because I know when I was there, you both talked about kind of how you do kind of play off one another sometimes, right? Like he's there and I think even during the last, we were scheduling our podcast and you said, oh, great, I can go help my husband. He needs help down. Yeah. So that's such an interesting dynamic to me. My husband and I work from home together. We don't work for the same company, but it's still like, we very much enjoy being there for one another when we need to. So I would love for you to talk a little bit about that dynamic. Like you obviously enjoy working together. And it seems like you guys do good work kind of together sometimes as well.
It's funny. Yeah. It's funny. I don't know. I guess with my critical care training, you'll hear, I feel bad for him because you'll hear everyone, they'll be like, oh, hey, Dr. Miles. He's like, are you talking to me or my wife is the real Dr. Miles? Because I used to do all the critical care and things for his patients, but he's incredibly brilliant. So he's an orthopedic trauma surgeon, which means that he mostly deals with broken bones. And that is his specialty. So not really ACLs or anything like that, but broken bones, usually from trauma, obviously. And so we talk a lot about soft tissue defects. So if someone has a big wound over a broken bone, how is he going to deal with that? And recently we had a pressurized injury case where the patient needed a lot of muscle repairs to have the best functional outcome. And so he did the muscle repairs and put together what made sense. And then I did the skin coverage for the case. We love working together. I think we're both really spoiled in the sense that we both understand, the time commitment. So you have someone who understands when you miss date night or something happens or you miss this event or that event. We're definitely a team. So he does laundry just as well as I do. So we're definitely a team. But I respect what he does immensely. And I think he does me, and it complements well because a lot of our patients are combined burn trauma patients. And so we often get to work together, and we enjoy that. I don't tell him how to fix bones, and he doesn't really tell me how to fix skin. So it works well to work together. But no, he's great. We love being in the same hospital. He would hate me saying this, but he was actually the orthotrauma surgeon on call for the Bourbon Street attacks. So was very busy towards the beginning of January. But yeah, I think the mutual respect is definitely there. And we also get some really neat ideas from one another, different perspectives on things that, coming from a burn background, I would never think. And he'll ask me questions. I'll think, actually, I think that may work. You're right. And it's funny to have these back and forth kind of dialogues about things, just because, orthopedics is trained in a totally different way than we are. So that's fun. Those are the kind of conversations that happen in our house, if anyone's interested. But
it's like a real life Grey's Anatomy. So don't tell him I said that, but it sounds like you guys are a real life. I love Grey's Anatomy, and I'm sure a lot of it is not real, but I still think that you and your husband are a real life Grey's Anatomy dynamic there. So,
well, the hospital had some type of Valentine's special where they were posting couples in the hospital, and it took me a long time to convince him that we should submit our picture. He was not happy about it, but we did it.
So is it on the social media page for the hospital?
It's on LinkedIn for the hospital on Valentine's Day. Yes, he was not into it. He was not into it, but I convinced him, and we did it, and he's going to be just fine. But yes, it is there. It is.
We will make sure we go there and both like it for you as well.
Yes.
Okay. Yeah. I had to drag him through the mud for that one, but
it's awesome.
How did you spend your Valentine's Day? Was it with each other?
Yeah, we did. We went downtown and had something to eat, and then Southeastern Surgical Congress is a conference that happens every year. It's in New Orleans this year. So a lot of people from my residency program that I graduated from were in town. So we picked them all up at the airport later that night. And so that was Valentine's. Yeah, that was Valentine's.
I wasn't sure if it was spent at the hospital or not. So it sounds like you guys had a true Valentine's Day this year.
We did. We had a real Valentine's. Absolutely.
Well, just before we head out here, so you do a lot of the American Burn Association mentorship. What impact have you seen on the field, and why would you have someone else, why would you recommend someone else to kind of be a part of that program?
Oh my gosh. Thank you so much for asking that. I love that question. Yeah. So, there's very few burn providers in general across all disciplines. There's very few of us. We're a small community, which is something that I love, but it also makes it sometimes hard to find a mentor within your own system, right? You become the new burn nurse educator. There's not another one of you, there's not someone else to ask. So through the mentorship program, you get paired with someone who is more senior than you are, who has experience in what you set to be your specific goals. So whether that be becoming certified as a burn nurse, whether that be, becoming a burn surgeon like it was for me, paired with a female burn surgeon as a resident was so impactful for me. And so you set out on those specific goals, and then you're paired with that person for a year. So you meet once a month with that person, review your goals, review ways to achieve your goals. And you would think you could figure those things out on your own, but like I said, with such a small community, it's not Googleable. It's not easy to find that information. And as welcoming as the burn community is, you still need somebody to open the door and say, hello, let me show you this person, or you remind me of so and so, they're doing this research, right? You would be interested in getting involved with that. So for me, completely transformative to be in that program. And to have a female burn surgeon mentor like that was so helpful, who is also married to a physician. So that was really helpful to help me navigate that and figure that process out. But yeah, I find it to be really rewarding. I always want people to know it's low stress. No one's judging you. I don't get a report card back on if you were a good mentee or not. I get no report card. It's literally just for your own edification and benefit and well-being and whatever you're looking to do or accomplish. And really mostly about that person, your mentor, helping connect you to people who can make what happen and just, help you navigate the system and the world of burn. So I think some people perceive that it's going to be a test. There's no test. And then there's this little survey you fill out if you had fun or not. But, other than that, there's no test. So I strongly advocate for anyone in burn care to please apply. I get those applications once a month. We do rolling pairings. Please apply and consider coming to our membership advisory forum this year. We're going to have me and my mentor there and a couple of other mentor-mentee pairs in other fields of burn, just to talk about that experience and how it really shaped us. So
I've been involved in mentorship programs, not in the medical field, but at two of my employers now. And I will say it does, one, open up doors, but I also think it's just a great forum for you to have someone to go to when you're like not wanting. Can you hear me?
Yeah, I can hear you.
I just think it's a great program. I don't know how much you caught, but I've done some mentorship programs at both of them one a previous employer and my current, I have one. And I think it's a great opportunity for you to ask questions, to get involved, to really even just to have someone to bounce ideas off of. And I think it's the same right across the board. Like mentorship programs are free. It doesn't cost anything. People are dedicating their time for you to do those things. So you can't be more inspired to kind of get involved and learn something new from someone.
It can't hurt anything. So
no.
Yeah.
Well, I know we're coming up on time, so we always ask two final questions on our show. My final question would be, if you were going to give anyone a piece of advice, you have lots of advice I know that you can give, but if there's any advice you want to give, maybe a new burn survivor, or parent of a burn survivor, what would that be?
Ask questions. So
you take your vitamins, Victoria. So.
Ask questions. I try to always encourage my patients, you're not supposed to know about what the other side of this looks like. Nothing about this is common in our culture. Nothing about this is something that's talked about at dinner frequently amongst people, right? Ask small questions, ask any questions. So that's the biggest thing. And if you are having trouble finding out who to ask those questions to, the Phoenix Society is amazing. So go through the Phoenix Society and they will get you someone to answer those questions. If you don't have someone, in your own community that's willing to answer them. But ask questions and know that nothing that you can ask is dumb or uneducated, or it just comes from a place that you don't know, So I think that's really important. Ask even the small things. So ask questions.
Because I also think we sometimes assume, right, that a doctor is going to know it all, right? And if maybe you're confused or you don't, it's okay to ask the doctor, why am I doing this? Right. What is it? What is happening? Just like the protein shakes, right? Why am I taking these? Right. I think it's really important and that you're open to it, especially as a physician. So I really, really appreciate that you said that. Cause I think, being open is a huge part of, this journey that we're on.
Absolutely.
For sure. And I'll make sure we do have our Facebook group and our peer support chat linked below, because if you're scared to ask questions, that's the place to go. You can post it anonymously as well. So if you're scared, you can post anything and no one even has to know who you are. So I think it's a great feature. I get scared sometimes or embarrassed to ask my dumb questions or what I think are dumb questions. But with that, Victoria, it is time for our final question. It is our Phoenix partner question today, sponsored by Grapper and Nejet, a personal injury law firm helping survivors and others get the financial representation they deserve. So their question is, what is one thing you hope listeners take away from the podcast today?
I hope that it helps burn survivors understand why we make patients uncomfortable. So I think it's often hard for me to do my job, but I know that sitting, resting, and sleeping is not going to get them to where they need to be. And that's not to say that pain should not be adequately controlled, because it should. That's not to say anything else except to say that maybe from this talk, people can understand a little bit of the method to the madness, of what our thought process is, and doing a lot of the things that we do and pushing a lot of the things that we push. Maybe it is a little more clear and a little more transparent as to why we do what we do. And, I think it's hard with very few burn surgeons and the number of patients that we have to sometimes sit and explain these things in the best way possible. And so I hope that it helps some people have better insight into the reasons we do what we do.
Well, it has been an absolute pleasure having you on. You've answered some new things for me, even as far out as I am from my burn injury, and I think Rachel as well. So thank you. We'll make sure too, if we have any questions in the show, that we route them to you to get connected. But with that said, we just want to thank you again for taking time out of your busy schedule to be a part of our podcast today.
Yeah, absolutely. It's an honor. Thank you, guys.
Yes,
Thanks.
Thank you so much.
We'll talk to you again soon.
Yeah.
Bye.
Thanks so much for tuning in to this episode of Girls with Grafts. If you are enjoying this content, please feel free to rate, subscribe, and leave a review wherever you listen to your podcasts. This helps others find the show, and we greatly appreciate it. Thanks again for listening, and we'll catch you in the next episode.